Hello, everyone. On behalf of Pablo Krastev DDS, also known as High Speed Pav, and that was back in the day. That was back in 1993 when I graduated dental school. I used to be named High Speed Pav, but then over the years I changed myself into the VGO man. I became the VGO man. How I became the VGO man, I have no freaking clue. One thing led to another. My brain, I got hit by a brick this way, this way. I became the VGO man. Now, VGO man, that's another discussion. But today's a big day. Yesterday was a very big day. We had Dr. Henry from Germany. Amazing presentation. Today we got some really special people. Dr. Pai is, she's a firecracker. We'll talk about her in a minute. And then, of course, we got Implant Mike. Implant Mike. If you don't know Implant Mike, you don't know, you don't know dentistry. Implant Mike from New York City. I should say in the suburbs. So it's going to be a great day. Once again, I welcome all of you on behalf of myself and Global Summits and Dr. Keanu Shah, who's the pioneer of this wonderful and explosive project that's taking over the globe of dentistry in terms of sharing, in terms of learning, in terms of being passionate about what we all do. So today I wake up, guys. Let me update you. Let's before we start, let me talk about a little bit what's going on. So I wake up today. I put a little video up for you guys to enjoy. Talk a little bit about my hair, because some of you must know, but I gave myself a haircut. It's filling in. I got it fixed up. It's all looking pretty good. And put on some threads today. I shaved. We're all looking good. We're gonna have a good day. So now, today my wife, we get up and I say, honey, I got butterflies. She goes, what? I said, because I got a big presentation coming today. She goes, don't worry, Pablo, you wing it always. But I'm nervous. Honestly, guys, today I'm a little nervous. And sometimes, like when I talk, I forget what I'm talking about. I have like a Biden moment, like I start talking about the thing. The thing. But anyway, that's so. Boss lady says to me today, Pav, we got a party going on. And really, guys, after the presentations are done today, we got a little bit of a barbecue going on in honor of my best friend's sister passing away. His name is Mr. Ervant. And we're doing a little barbecue for their sake and, say, thank you and to express our condolences to my brother, Ervant. But anyhow, so boss lady asked me to be on my best behavior today, and I will do my best to be on my best behavior today. And when the Godfathers arrive, and I really mean literally the Godfather, because one Mr. Vince will be coming over today, and he's the Godfather to my daughter Melania. All right, and then we got another Godfather coming over. We're going to talk about a few things, exchange some information. You know how it is, it goes. So I'm having another biting moment. I don't have a teleprompter, guys, so I got notes. So I'm gonna read my note. Oh yeah, all right. The guys at the Global Summit, I got some pull there. Just a little bit. A couple of good friends, but they kill me. They put me up with these handsome devils every single week. Guys with these resumes that are like long, like longer than long. So I begged them. I said, guys, I feel like I'm a caged animal all week long until the weekend comes. And when the weekend comes, I'm like, I sharpen my horns. I'm like a raging freaking bull. Like that type of bull. A week I'm like scratching my hoofs. And then finally the weekend comes, and I got a problem. I got to host another guy. But see, so I made a few phone calls. I spoke to a couple of people. I said, guys, let me talk. Let me host one day a beautiful woman, a woman with brains. And I got to tell you all, you guys out there, there's nothing sexier than a woman with brains. the one you want to talk to for a long time. And today, I'm nervous. I think she's a little bit nervous, but I'm going to introduce to you guys in a moment uh, someone that's a role model, someone that is spectacular in the practice and art of dentistry, and more specifically, oral and maxillofacial surgery. Someone that is trained in areas that I certainly don't know much about, but she'll share her passion and her knowledge with all of us today. So let me go through her resume a little bit, and then I'm gonna introduce her formally to you guys. So, Dr. Pai, welcome. It's a pleasure to finally meet you
Thank you. Thank you.
live. I mean, I've met you before, but live here.
Thank
And I
you.
welcome you on behalf of myself and Dr. Kiano Shar and Global Summits. And it's going to be our honor and our pleasure to share your knowledge with all of our friends across the globe today. So let me just read your resume a little bit, and then I can't help myself. I gotta say, I mean, passion. When you meet someone with passion, such as yourself, a woman that's accomplished everything in such a short period of time, I salute you.
Thank
The
you.
world salutes you, and it's really our honor that you accepted our invitation to this partner today. So let me go through your resume, okay? Oh boy! All right. See, guys, this is what happens when you get to my age. You got to change glasses. I could talk about my glasses next week because my favorite pair is broken. Oh my god! See, I got that. I got a 999 pair, like nine. Like, hold on a sec. Let me tell you guys about my glasses. I got my $1,400 pair here. This is the ST DuPont. This is Costco $9. See, but they broke. So now, like, this piece doesn't close. So of course, we as dentists we can fix anything and everything. So I glued it together. I prefer these over the expensive ones because I can't read with them. But all right, so let's get to the resume. Dr. Pai, once again, on behalf of Global Summits, welcome, and
Thank
let's
you.
go through your resume. Dr. Sangeeta Pai completed her undergraduate studies on top of her class with honors and a gold medal from SDM University, India. Dr. Pai secured her oral and maxillofacial surgery training from PLC State University. I probably butchered that one up a little bit. And further worked in various universities in Germany in the Department of Oral and Maxillofacial Surgery. She dealt with oncological plastic surgery, cleft lip, and cleft palate, head and neck tumors, and extensive facial reconstruction. I wonder if you've met Dr. Vishy Brahman. I mean, Dr. Vishy Brahman is also an authority, absolute authority in the United States on this topic. So, I mean, this is very exciting stuff. Dr. Pai did her super specialization in minimally invasive sinus augmentation procedures, augmentation implantology in Paderborn, Germany. I tell you, I love Germany and I love German products. And in my practice, I don't work with instruments, anything other than made in Germany. Period. Over the years, she developed keen interests in aesthetics and surgical full mouth rehabilitation. Dr. Pai specializes in extensive bone augmentation and reconstruction in the field of implantology. Dr. Sangeeta Pai is currently practicing as a consultant surgeon and implantologist in private multi-specialty clinic in Oldenburg, Germany. Dr. Pai holds a fellowship in International Congress of Oral Implantologists and is a fellow affiliate in the Royal College of Surgeons of Edinburgh. She holds certification in sedation and certification in PRF, platelet-rich fibrin, folks. That's the new thing these days. PRF is the way to go. The old stuff, forget about. PRF is the way to go. She is a key opinion leader for various German and international implant and biomaterial manufacturers. She was selected as the recommended doctor in the region by Germany's Focus magazine, peeps, 2020. That's serious business. She has recently been selected as a young international speaker for German implant system. Dr. Pai, you gotta tell us more about that. She has published in various international journals and is active in clinical research. She is currently working on various new minimally invasive bone reconstruction techniques. She strongly believes in hard work and perseverance, and with that, no goal is impossible. Now, wait a second, peeps. Before we get into this, let me tell you, wait a second. Listen, guys, I want you 6 feet away from me. Guys, back off. Yep, back up, back up. I got a freaking tape measure. I want a 6 feet parameter around me right now. I'll probably poke myself in the eye with this, but we gotta respect the Corona business, and 6 feet. All right, peeps. 6 feet, back off. All right. So now, having said that, I'd like to invite Dr. Pai. Dr. Pai, please tell us a little bit about yourself. Tell us what inspired you to go into dentistry, and how did you end up in Germany? I mean, I'm going to ask you 10 questions now, and please shoot free. Tell us your life story. Share it with us, because this is what we do with Global Summits. We share our knowledge, our passions, our good stories, our bad stories, our sad stories, our painful stories. We love to share everything and with everybody across the globe. And that's why we're here today. So, Dr. Pai, please tell us a little bit about yourself.
I basically come from India. So after my graduation in India, I got a scholarship to do my postgrad. So that's the way I ended up in Tbilisi State Medical University. During the same time, I did a fellowship in UK in Royal College of Surgeons. And then we had an opportunity to come to Germany, but the language barrier was a loop what we had to take care of, and me and my husband, we saw to it that in 6 months we learned the German language. We got our certification here, we got our degrees approved here, and yes, what can I say? The love of my life and the passion for surgery has made me stay and continues to make me stay in Germany. Yes.
Wonderful, wonderful. So why don't we get rolling here and see your wonderful presentation, and at the end, I'm sure we'll take some questions.
Yes.
If anyone has any, and please, I turn over the podium to you, and let's rock and roll. And
thank you, Dr. Costa.
Thank you for joining us.
So, thank you, Dr. Costa, for the wonderful information about me, for introducing me, and for the wonderful gig, what you usually do. It really fascinates us. The energy level you have, it is really awesome. So, good evening to my dear friends. A big hello from Germany. Today we have a very challenging topic on hand. Therefore, the name Demystifying Bone Augmentation in Implant Dentistry. Here we will be talking about a little bit of theory. There is a pinch of practical, and we will be ending our journey today with a few amazing clinical cases. So, augmentation. Augmentation comes in question when we have ridge defects. And as we all know, ridge defects develop as a result of surgery, trauma, infection, or congenital malformations. The goal of bone augmentation is maintenance of the contour, elimination of the dead space, and to reduce the post-operative infection, therefore enhancing the bony and the soft tissue healing. It's a well-known fact that the insufficient quality of the bone is due to the loss of rapid resorption of the alveolar bone after removal of the teeth, because the stimulation of periodontal fibers doesn't function. For example, pneumatization of the maxillary sinus after removing the posterior maxillary teeth. So augmentations comes into action when we have less of bone or bone loss. Bone grafting is a surgical procedure that replaces missing bone with material from patient's own body, an artificial, scientific, or a natural substitute. Bone grafting is possible because the bone tissue has the ability to regenerate if provided mind you, if provided the nutrition and the space to grow. So these are the very important factors which decides how the bone is formed. Talking, as I told you, we'll be talking a little bit about theory. The bone augmentation material is divided on mode of action. So the first one which awaits us is osteoconduction. Osteoconduction is when the bone graft material serves as a scaffold for the new bone growth. The osteoblasts from the margin of the defect that has been grafted utilize the bone graft material as a framework, as a matrix to spread the new bone. The most common osteoconductive bone grafting materials are alloblasts and xenografts. We will talk about allo and xenografts in the coming slides. Osteoinduction. As the picture indicates here, you have the mesenchymal cells which differentiate into various different cells, and the osteoblast is the reason why we have the new bone. So this involves stimulation of the osteoprogenitor cells to differentiate into osteoblasts and then begin formation of the new bones. The most widely studied type of osteoinductive cell mediators are the BMPs. A bone graft material that is osteoconductive and osteoinductive will not only serve as a scaffold for the currently existing osteoblast, but also triggers formation of the new bone, which is the basic of biology. So the most common known allografts and demineralized bone. So these are the materials which have a feature called osteoinduction. Osteogenesis. Osteogenesis occurs when you have vital osteoblasts which originate in the bone graft material, which contribute to the new bone. So you have your autografts, that is the patient's own bone, and you have the allograft with cellular bone matrices. Continuing our journey into bone augmentation material based on the source. So I have depicted here a few things so that it's easier for us to understand. Autograft is, as we all know, patient's own bone. Autologous or autogenous bone grafting involves utilizing bone obtained from the same individual receiving the graft. Bone grafts can be harvested from non-essential bones, like the iliac crest, you have the mandibular symphysis, you have the mandibular ramus. We also nowadays harvest the bone from maxillary tuberosity. So when a block graft will be performed, the autogenous bone is the most preferred because it has less risk of graft rejections, and as it is originated from the patient itself. It is osteoconductive, osteogenic, and osteoconductive. So all the three factors are available here. What is the disadvantage? Autogenous is wonderful in all ways, except you need an additional surgical site. Surgical precision is required. It is not a cakewalk, if I may say. So you need your surgical skills to be really good. The resorption rate, another potential location for post-operative pain. Coming to the resorption rate, unfortunately, there are not many studies. There are studies which show what is the resorption rate from using the autogenous bone grafts till we place implants, but not after that. So there are a few studies like the Midmark et al. Study in 1997 and the Cordaro et al. Study in 2010, which shows that there is around 28% to 23% of bone loss respectively after we do autograft. So this is a picture where we see we have grafted the ramus into the defect, stabilized it with two beautiful screws, and the space between the graft and residual bone is filled with the patient's autogenous bone chips and allograft material or the xenograft material, which is mixed in 1:1 ratio. I tend to do that very often where I mix two materials, the autografts and the xenografts, and put PRF, and you have a sticky bone which is very easy to manipulate and has all the good things of blood ingredients in it. Coming to the allografts. What are allografts? Allografts are grafts that are derived from humans. The difference is that allograft is harvested from an individual that is other than the one receiving the graft. That means that the species is the same, human to human, but the donor, it's a donor bone. So there are three types of bone allografts that are available. You have the fresh frozen bone, you have the FTBA and DFTBA. So the use of allografts for bone repair often requires sterilization and deactivation of the proteins normally found in the healthy bone. Yes, they are taken care of with acid, hydrofluoric acid, which then has the mineral content of the bone is completely degraded, and the osteoinductive agents remain in the demineralized bone. This is the way the allografts work. So this is a beautiful picture where you can see allograft plates, which are available here in Germany from a company called as Botis. I usually tend to use when I have cases where I don't want to go invasive. It works really fine where we place or stabilize the bone grafts or the bone plates with the screws, a sandwich technique as usual. Put your autograft, xenografts, mix it with the blood, put a beautiful membrane, and it works fine. You have to just take care that you round off the sharp edges because it comes in a block, and as you can see, I have rounded off the edges and close the flap without tension. Synthetic variations. So artificial bone can be created from ceramics such as calcium phosphates, the flexible hydrogel hydroxyapatite composite, which has a mineral to organic matrix ratio, approximating that of the human bone. So they are biologically active depending on the solubility in a physiological environment. These materials combined with a growth factor, so I usually tend to use, when I'm using synthetic variations, tend to use it usually with a PRF so that I get the best result when needed. Xenografts. So xenografts is my favorite material, which I use in more than 70% to 80% of my cases. You have xenografts are from the species that are other than human. As you can see in the picture, you have the bovine, you have porcine. There are some companies which also have equine, that is from the horse, and are used as calcified matrix. So they are basically osteoconductive and help in scaffold bone formation and are available in different range of volume, particle size. So this is the best thing which I like about xenografts. You know, you have possibilities to have it in a syringe, you have different sizes, different particle size, different amount, different volume. So my personal favorite is I tend to put or use, when I'm doing large procedures like external sinus lifts, I tend to use the bigger particle size, which helps in bone formation quicker because it has the capacity for neovascularization. So one need not forget the barrier membranes. Barrier membranes is something like water control forces, you know, which guides the bone to stay where it belongs and the soft tissue to migrate as we wish for. So membranes are routinely used to maintain space, as I just said. There are two kinds of barrier membranes. You have the resorbable and the non-resorbable membranes. Am I clear? Is the presentation going on fine?
Yeah, it's going good.
Okay, fine. I just wanted to check because I cannot see. Fine. Coming to the resorbable membranes. The most important advantages of the resorbable membranes are elimination of the membrane removal after healing. That means that you don't have to remove the membrane after the primary healing. Therefore, resulting in decreased morbidity, easy manipulation, and lower rate of complications. I tend to use resorbable membranes in almost 80% of my surgery, and it works wonderful. Just a little tip there that I tend to stabilize the membranes with small pins or a suture, you know, with a periosteum so that you are sure that the membrane is stable enough. The stability plays a very important role when you're using resorbable membranes. So the resorbable membranes that are made of native collagen show high biocompatibility, resulting in good tissue regeneration and rapid vascularization. Coming to the non-resorbable membranes, these are my choice when I do cases like full mouth rehabilitations where I have to practically build the whole upper and the lower jaw. Then I go for non-resorbable membranes, you know, where a high amount of bone augmentation is required. Reinforced non-resorbable membranes are used. Why? Because due to the titanium that is present in these membranes, it withstands the pressure from the surrounding tissue and therefore resulting in prevention of membrane collapse and allowing the bone to be regenerated. Titanium mesh, you have titanium reinforced polytetrafluoroethylene, the PTFE and the DPTFE membranes. There are also some membranes, you know, it is just like a titanium mesh. I personally do not like them because they always tend to make me problems. I always have open wounds. So when you go for membranes, according to my opinion, go for non-resorbable membranes or resorbable membranes, not the metal titan mesh. So after we have got our theory in line, the keys. What determines the success of the bone augmentation? So I have divided into 4 pillars. The first one is patient-related. Second one is the technical, biological factors, and post-operative care. Before jumping into this, it's very important that we speak to the patient about his dreams, his wishes, what is he or she expecting as a result from the surgery which we are planning together, so you have to, I personally take a lot of time in my first appointment to tell the patient that it is a two-way road. I can do the best surgery in the world, but if he or she doesn't take care of the wound for the coming days, then you can always expect complications. So it's very important that you speak to the patient and do customized patient plans. So as we spoke, patient communication is the key. The second one is customized road plan. Customized road plan, because it could be possible that two cases look similar. You have a missing tooth, you have less bone, and then you say, okay, the allografts or the xenografts with a membrane, with a closure worked fine in patient A will be working fine in patient B. No, you're wrong, because there are other factors like the general health. So you have to be very precise, even though being a dentist, even though not having too much of medical information, we are bound to have the needed medical information. Like if the patient has diabetes, is he on anticoagulation agents like the blood thinners? Does he have blood pressure? What about osteoporosis? Does he take vitamin D? Does he have malignancies? Does he have a history of radiation due to these malignancies? Because all these factors change the road plan and therefore change the treatment modalities. Third point, the oral hygiene. It's very important to analyze and to see where the patient values his oral hygiene. If the patient is smoking, patient's periodontal health, how about the general oral hygiene of the patient? So it's very important that we do the professional cleaning before we go in for big augmentation procedures, etc., etc. And then I usually tend to do a control after the professional cleaning where I say to the patient, so it's good, but it has to get better. And I motivate the patient, if they are smoking, to reduce the smoking, so that the patients are mentally prepared. So it is very important to have a kind of a holistic surgical approach so that you talk to the patient. Only we, being surgeons or dentists who do the procedures, doing 100% without telling the patient that it is a 50-50 job, we cannot attain the results we are wishing for. So, patience and trust, yes, it plays a very important role that the patient trusts you. Because when you're doing big cases, when you're telling, okay, I remove all the teeth, I do the augmentation, and I do the closure, wait for 6 months, 5 months, 4 months, whatsoever the way we do it, and then place the implants, wait for 2 months, open them. We are talking about a journey from 6 months to 9 months. So almost an year. So the patient has to, first of all, feel comfortable, has to have confidence in you, should know that he's in good hands. So all these things also play a very important role. The last one is the good planning, and good planning gives you predictable outcomes. So the technical factors. As I said, analysis of the case is very important and tend to do a plan from A to Z. So begin with end in mind. And nowadays, we have wonderful opportunities to do radiographs. You have CBCTs, you have intraoral scanners, you have models which you can prepare data, upper and lower alginate impressions, and you have the model in front of you, and you know what information is required. So do your homework, spend your time in analyzing the patient customized. Treatment option, fixed or removable. Removable, it comes in question not in single implants or the bridges, but when we are doing multiple implants with rehabilitation, full mouth rehabilitations. The last point is planning and execution. Yes, now we have in our practice, we have the possibility to ask the patient if a general anesthesia comes in question, local anesthesia, sedation, and believe it or not, more than 50% of my patients are anxiety patients, are phobic patients, are patients who, come to me with bad history, who were mishandled by the dentists or the surgeons, or in childhood and childhood trauma. So it's very important that we tend to help the patient that many steps, many surgical steps are done in one go. So general anesthesia comes in question where you say, so it's very important. You cannot always say every 6 months I'll put the patient in a general anesthesia. It doesn't work that way. So you have to take care which are the steps which you can combine so that it is less morbidity for the patient. So patient should be the center of our discussion or the planning factor, important factor in planning our surgical path. Coming to the biological factors, we will talk about all the factors in detail. So it's stability, the perfusion, suturing and closure without tension, and platelet-rich fibrin. Stability. So as I told you, it is my day-to-day activity when I do large augmentations. I don't tend to place pins when I'm doing single tooth or two teeth. More than two, I usually tend to place these little soldiers. They're the pins who stabilize my membrane. So the stability of the augmented site in GBR applications during healing is an important factor for achieving success. The initial blood clot formation and stabilization of the graft particle will result in predictable bone formation, although barrier membranes will cover the augmented site and exclude the epithelial connective tissue from regenerating bone. Additional tools are needed to provide stability and also to increase the resistance of the augmented site from the flap, lip, masticative muscle. So, as I said, the stability of the augmentat, what we put in the bone, is very important to attain the success what we wish for. So it's very, very, very important that we work hand in hand with the nature. You can't work against the nature. I'm telling this because prior, when I started with my surgery, we always had believed that, okay, over-augmentation is a way to have better results. No, it doesn't work that way. Respect the nature in the way where you say bone belongs where it belongs, and from the border, the soft tissue has to start. So you have to respect where your limits are. So it's very important that you don't over-augment. Perfusion. The primary source are the cortical and the cancellous bone. The secondary source, as we all know, is the periosteum. So it's very important to handle your operative sites with care. Therefore, minimally invasive flap designs, the tunnel technique, what we have, the semilunar flaps, and if there are cases which we have, which each one of us have, where you have full mouth rehabs, where you have to remove all the rest teeth, where you have to place an incision which goes from, maxillary tuberosity to maxillary tuberosity, I tend to place it in the upper jaw more palatally, and in the lower jaw more lingually. So I'm very kind to the buccal soft tissue where we can then close the flap without much tension. Platelet-rich fibrin. So I really swear by this mechanism. The way it works is really fantastic. I'm doing this in my practice past 2 years, so I can really recommend you this. It really works like magic. What is PRF or LPRF? It's a second generation PRP where platelets and leukocytes are present in a complex fibrin matrix to accelerate the healing of the soft tissue. So in layman term, it's just like a biological band-aid. Victonectin. So you have all the good things what is in the blood in this beautiful membrane, and it really helps in healing. The morbidity of the patient is so low, the patient doesn't have pain, the swelling is reduced, the healing of the bone is amazing. So it is a really wonderful technique to enhance predictable results and less morbidity to the patient. So to obtain PRF, you need to, the blood is drawn, of course, from the patient and in the test, and put it in the test tube without an anticoagulant and centrifuged immediately. So the resultant product, as you can see in the test tubes, you have different layers. The topmost layer is a platelet poor plasma. Then you have a PRF clot in the middle, which is rich in all the wonderful molecules I just spoke about. And the third layer is the red blood cells. So PRF is available as a fibrin clot. You have various ways how you can use this PRF. As I told you, you can make it in a membrane. You can use it as a clot. You have possibilities to even use IPRF, that is the liquid, which helps you make something called a sticky bone. So as you can see, the first picture shows the case where we have the complete bone missing in the buccal bone, and I tend to usually perforate my rest bone when it is a very large area, which I augment with a very fine diamond round burr, so that the blood is oozing, yeah, so that all the good things of the blood is accepted by the bone material. I mix it with the autogenous bone from the patient. I just scrape it with, you have something called a safe scrapers or micros, where you can just tend to scrape the normal bone of the patient and mix it with this allograft, xenograft, whatever you're using, and make a beautiful sticky bone out of it, which is really malleable. You can really work with the bone. Put a membrane and suture it, and yeah, it looks so beautiful. Look at it. A wonderful bone with really good blood vessels and very stable, and you place beautiful implants, and it's a good day. Good. Coming to the post-operative care, it's very important, as I told you, that the patient takes good care of himself or herself after you do the surgery. So antibiotics with risk patient. I tend to give patients who smoke, patients who have artificial heart walls, patients who have undergone radiation therapy due to cancers and all the malignancies. They are my risk factor patients. So I usually tend to give them antibiotics. I start antibiotics, either it's clindamycin 600 milligrams 3 times a day before the surgery, or amoxicillin 1000 milligrams or 1.5 milligrams 3 times a day before the surgery, a day before the surgery. Because I have this concept where we say, okay, you have a antibiotic coverage before, during, and after the surgery. Not all the patients, just the risk patient, because I'm very particular and very conservative about who gets antibiotics because of the resistance. Pain medication, as we all know, non-steroidal anti-inflammatory drugs, the ibuprofen, what you have, and the diclofenac, what we prescribe. Be generous in prescribing those medicines and tell patients that they can take them, because after big surgeries, it is really a big, leap into pain. So I tell my patients to do not wait till the pain starts, Take the pain medication half an hour to 45 minutes after the procedure, and they are good to go. Because once the threshold of the pain is already pushed down, the patient have less discomfort, as per my personal practical opinion. Cooling the region, intermittent cooling of the region works wonders after the surgery. Rest and no strenuous activity. Yes, as we all know, soft food. Yeah, 3 post-op checkups in 2 weeks. Yes, I'm very particular that after the surgery, the patient comes to me on a Friday, because in Germany, Saturday and Sunday is non-working days. So a Friday, I tend to call my patient for the post-operative check, and believe it or not, patients are really happy to come down so that one can have a look, because they have this feeling that the doctor has taken care of, the surgeon has taken a look, and everything is fine. Because it's completely normal when you do procedures and the patient has such, half of the face is swollen like a hamster, and if you do not check, then the patient ends up in emergency dental care, and the colleague probably knows the technique, doesn't know the technique, opens it, and you are on ground zero. So you start again with zero. So I'm very particular that the patient comes to see me on Friday before we go into our holidays or the weekends. So remove. Yeah.
Yeah, sorry to interrupt. Your actually video has become still. So your voiceover is coming fine, slides are running fine, but your picture has become still. So if you can switch on or off your camera once.
Okay. So I will just switch
Yeah.
this off. One second. Is it good now, Anshul?
Yeah, I can see it. I can see it.
Okay.
Yeah.
Okay.
Yeah.
So can I go to my presentation now?
Yes, please.
So now I can. Is this okay, Anshul?
Yeah, it's fine.
It's working fine?
Please continue.
Wonderful.
Yeah.
Wonderful. Then let's continue. So the post-operative care. Coming to the complications. So, my dear friends, it is a difficult fact to accept, but I think each and every one of us have cases of complications, because I see them as steps to success. You know, failures, the ones we have, the cases where you say, oh my God, it's really not working the way I wish or way I want, teaches us what are the things we need to take care in future. So late complications, early complications. Early complications include wound dehiscence, membrane and graft exposure, and infection, with the most common complication being wound dehiscence. Late complications include rejection of the implant, sequester formation, osteonecrosis, and a strong correlation has been between the flap tension and wound dehiscence. So take care that the flap is closed without tension. You know, it is very, very important, because at least in case of augmentation of the bone, once a complication occurs, it is just a wait and watch. You cannot do much about it. So prevention is always better than cure. Patience from the patient and the surgeon. So as a surgeon, we are very eager, you're very scared and tensed, and you're like, okay, my God, there is a lot of slurry coming out, pus oozing, or the bone that is you had put in with so much of hard work is oozing out. Sorry, but you can't do anything. You have to just wait and watch. When there are small exposures, or you have dehiscence of the membrane, which are very small, I tend to usually granulate the edges and let it bleed a little, so that the granulation tissue is formed. And as we all know, granulation tissue takes 10 to 14 days to form. So be patient during this time. I have a very good experience with Blue M. It's a gel out of oxygen and honey, so everything is natural. And I really tend to use this when I have cases of wound dehiscence. Thank God I don't have that many cases, but touch wood, when I have such a case, then the Blue M is, a savior, as I say. Good. A large dehiscence have to undergo surgical refreshing of the wound and resuturing, as we all know. But I tend to wait at least 14 days if something like that happens, so that at least the bone which we have augmented is a bit stable, and then you just remove the free bone which is hanging and clean it, freshen up the edges, let the wound bleed a little, and suture it beautifully. So the complications may be prevented by careful preoperative assessment and planning, which augmentation procedure suits the patient. So as I always say, custom plans and patient-oriented. Minimally invasive flap elevations and careful reflection. Yes, you have to always respect the tissues you're handling, because when you carefully handle your tissues and your operating area, it really heals well without any issues, because you have all the blood vessels, most of the blood vessels intact. Appropriate instruments and proper suturing. Yes, invest in armamentarium. When you have good instruments, it is half the work done. So please invest in good instruments and learn the techniques well before you try it on the patients. Sensible temporization with appropriate modifications, rebasing and relining. Yes, please always consider that when patients have RPD, removable partial denture, I always request my patients to keep them aside for 10 days at least, because it's a known fact, when we have a fresh wound where you do augmentation to the flap closure, there is swelling, there is edema, which is a normal reaction to the surgical steps what we have done. So on that, imagine putting something which doesn't fit at all. You are putting external pressure on the wound, which is also a reason why dehiscence occurs. So take care and tell the patient to, if possible, remove the RPDs and cool well and take good care of himself or herself. So my dear friends, we are coming almost to the fag end now. We will be seeing a few cases. So let's start with the first case. Oh yes, this was a young man, 32 years old, from US, and I got this as a recommended patient sent over here to Germany. He was visiting one of his friends here, and he visited our practice. And yeah, unfortunately, the patient has a history of trauma when he was very young. So one was extracted after all the surgical procedures, which which are possible. I mean, root canal treatment, they did an episectomy, they did a second time episectomy, then removed the tooth, and then placed an implant. Unfortunately, the implant failed. As we all can see, there is not only a bone defect, but also a soft tissue defect. So there are two things what we have to take care of. The radiograph, as you can see, shows a uber big implant, which is way bigger than the anatomical width of 1-1, and 3D, that is the CBCT. Unfortunately, I have not involved it or put it here, showed 1-1 and 2-1 and 1-2 periapical infections, which goes up to the nasal bone. So then we decided that we will be extracting these 3 teeth. As you can see, the complete buccal bone is missing here. Yeah, so what did I do? I did a normal procedure of GBR, xenografts to patient's bone. I took a piece from the maxillary tuberous, mixed it, crushed it nicely, mixed it with the xenograft, PRF, and sutured it back. I also did a diastema operation so that the pull from the maxillary tissues is relieved. After 4 months, voila, you have wonderful bone. Look at the beautiful breadth of the bone, the, a good, healthy, good vascularized bone. And as you can see, my flap design, it is placed a little more palatally as compared to buccally, so that I can, close it, and 2 beautiful implants. Coming to the second case, this was a very challenging young lady, 48, and she had a family history where one of her friends, colleagues, I don't know, got an external sinus lift done, and unfortunately ended up in hospital for a month because the whole augmentation in the sinus got infected. And she was really scared. She was really terrified with the word sinus lift. So she came down to me, and I spoke to the dentist, what we can do here in this case. So when I analyze this case, I realize that when I tend to do a sinus lift in this case, I will tend to put more bone in the sinus, of course. What about the missing bone here in the oral region? I won't be able to do it. To build that bone. So then I decided, as the patient was completely against sinus lift, that we do a vertical bone augmentation. The patient also didn't agree for taking a piece of the ramus, no autogenous bone. So then I went for the allograft plate, as you may say, and the good thing about this allograft plate is you can cut in the size and the width you want. So stabilize it with 2 screws, and the space between the patient's own bone and the plate is filled with autogenous bone and the xenograft, which I usually do. Closure and place 2 beautiful implants without any issue. Unfortunately, I'm still waiting for the prosthetic fix from the colleague. So moving on to sinus lifts. I love doing mini sinus lifts. I really love the minimal invasive techniques where we don't really open the conventional sinus, very patient oriented, indicated sinus lifts where we prepare the small window, and we will be able to. So a small video here where the Schneider-Schrein membrane, or the membrane of the sinus, beautifully moves with the patient's breathing. So when you see something like this, you can be really very proud of yourself that the elevation is perfect. So there is no perforations, and when the Schneider-Schrein membrane dances, my heart dances too, and I'm doing such a surgery. Okay, so the same procedure. Placed the implant, did the closure, and we are having a solution there. Okay, this was also a very interesting case. A little bit about the patient. The patient is in his mid-60s. The patient had a history of taking an anticoagulation, and double anticoagulation for that matter, because he's got a stent and he's got other heart issues. So after speaking to the general practitioner, me and he decided that we have to do minimal surgeries as possible, because due to his general morbidity, it was not possible that we do many surgical procedures, because there was a risk of extreme bleeding. So here we did a conventional external sinus lift, where we placed the window, elevated the bone. I usually tend to place a gauge once I elevate the sinus membrane, because it maintains the space. It relieves the pressure on the Schneider-Scheier membrane. So take a break. After you have elevated, you can take those two moments, the 2 moments of joy, to celebrate that you elevated the membrane so beautifully. And the gauge does it work, where you place it with saline and wet it and put it inside, and after 2 to 3 minutes, when you remove it, you will see a very stable membrane. You know your workspace, you know where you have to work. So I here then place 3 beautiful implants, proudly standing soldiers, as I say, and put a little bit of bone, autograft, xenografts, allograft, whichever you work with works fine here, and close the suture. So you have this. The next is a very wonderful case, very, very close to my heart, because it is a technique which I'm still working on and planning to patent it, and all the paperwork is still going on, so I'm not going to talk too much about it. But it was a case, let's concentrate only on the upper jaw, where the patient came with pain and swelling in the upper right quadrant, and after we did a 3D X-ray, we got to know that there is an cyst which extends up to the maxillary sinus. So it was a known fact that the sinus will get opened. Nevertheless, the same thing happened as awaited, that after removal of the teeth, the sinus was open. And then I thought, why not try something else? And I did, in the same sitting, a membrane and augmentation, closed it all in one go, because the patient was, very, how do you say, obedient, if I may say so, that you have some patients, right, where you say, please take good care of yourself, do this, do that, and they're very obedient. They take really good care of themselves. There are some patients who say, I don't care. But I tend to do too many things in one, only in the patients whom I trust. So as I said, the trust, it plays a very important factor. So we did the bone reconstruction in the same sitting, and this is the X-ray after the, this is the X-ray after the bone augmentation, which is done. 4 months later, I placed an implant, 2 implants, one in 1.5 and 1.6. I did a small internal sinus lift in 1.5. As you can see here, there is a a black dot, what you can see around 1.5, which completely calcifies or regenerates in after four months. So yeah, we placed 2 implants and did 2 beautiful crowns, and solved this case. The second last case we'll be talking about will be about full mouth rehabs. A history about this patient. Is very angry, is very scared, because he always had no how do you say, success in periodontal surgeries, unfortunately. There is also patient-related factors, his health, he had diabetes, he smokes like engine, if I may say so. So, it's not only the way we surgeons, we dentists work, it's also the patient's part of the job. So unfortunately, it didn't work. All the teeth were more or less mobile. So then we decided to extract all the teeth, did a beautiful bone augmentation, and as the patient was smoking, he didn't get anything more than full prosthesis, because I didn't want to take risks I could have placed 2 to 3 temporary implants so that stability, but I did not do it in this case. So after 4 months, we did a proper 3D planning, and on the left side you can see this is the planning what we have done in the CBCT, and placed all the 6 implants, did the usual connective tissue grafts, the palatine tunnel technique, and sutured it back. And these are the implants ready to go. And then we did, in his case, a complete, as he wanted fixed, it was his wish, and we then decided to go for it. So it is a completely screwed in zirconia bridges, which are in patient's mouth for 3 years, and we do regular checkups, and everything works really fine. And I have to tell, I'm very impressed with the patient now. I don't know, because of the money he invested. 12 implants with the wonderful fixed zirconia bridge costed really a nightmare for him. He's become very precise. He smokes just 2 cigarettes where he's used to smoke 12. So, you have very different ways to motivate your patient. Fine, my dear friends. Coming to the last case we have today. So this is a very wonderful lady who is very unhappy with her oral status. She also has a history of multiple periodontal surgeries. The teeth are more than grade 2 mobile, and she got extraction, a few teeth extracted. We tried to save the other teeth, and yeah, and she's very, very unhappy, very sad, and now has met the love of her life. Yeah, so she comes to me and says she wants a solution because yes, she has to, or she wants to start with her life. So after speaking to the periodontist, we decided to extract the rest teeth, and here I did all-in-one procedure where we removed the teeth, where we placed all the 4 implants, where did the bone reconstruction, 4 implants in the upper, 4 implants in the lower, bone reconstruction, and everything all in one go. And as you can see, I have the xenograft. I very carefully pick my autograft. After you drill for implants, you usually have the possibility to clean the burrs what you have for the autograft. And I took a little bit of patient's own bone, as you can see, and grinded it a little so it's in a good consistency so that I can put it back and sutured it. After I placed the implants or opened the implants after 4 months, I did a test drive, because before you purchase a Porsche or a Ferrari, you do a test drive. So I did a test drive here with the temporary provisionals what she got, and she wore it for 3 months. And I have to thank wonderful colleagues which I have in my practice who are trained prosthetics, and they take up my prosthetic work, where we do 3D checkup of the TMJ, which is called as Brustvermessung here in Germany, and the seeing how the upper jaw relates with the skull, and the upper and the lower. So they do that part of the job. So wonderfully placed implants, and in the lower mandible I had to do free gingival grafts. So that's the reason you see a little bit of scar tissue there. And for 8 implants, and yes, and we have really beautifully placed bridge, zirconia bridge. It has screw routine. That means that if there is any issues, you can always remove the whole construction. We tend to do a regular checkup. I usually, after I place or give patient a full mouth rehab, like in this case, I tend to call the patient after a week so that I can check for any occlusion points. I check on the day, of course, the anterior sliding, the posterior occlusion, and then tend to call the patient after a week, and again do a checkup in 2 weeks, and then the patient comes back to me in another 3 months. And then we do all 3 months a checkup. For the first year, after doing something like this wonderful full mouth rehabs. And then I speak to my dental hygienist, and we see what are the things which we have to take care of, tell the patient, and then we decide we will be meeting another all the 3 months in the coming year, or we say no, 3 times a checkup is enough for the patient. So yes, it's very important that the checkup after doing these kind of full mouth rehabs is strained upon and taken care of. So here we have a wonderful patient a very happy one, as you can see here in the last picture, and she can go on with her life now. So coming to the fact and takeaway point. So as we spoke about, the successful augmentation and implantation is our aim, is what we wish for. So there are a few things what we have to take care of: patient communication, custom-made patient plan, talk to the patient, see what is the best material for the patient, the best technique for your patient, whether you have to do it in general anesthesia and local anesthesia and sedation. So, you know, that first part where you put your time is very, very important, you know, because there is a phase of life where when you are a beginner, you know things, but you don't know how to do it. After a few years, you know things, you know how to do it, but you have not done still. Then after a few years, you know how to do it and you have done it. So it is a conscious effort where you put. And after another few years, it is at a subconscious level, you do the surgeries which awaits you. So until you reach this level, the stress has to be on making a proper plan. So custom-made patient's plan is very, very important. Analysis and planning. Yes, we have nowadays the possibilities that we do smile designs, that we do CBCTs, that we take X-rays. If you are still the old school, like me, I like to have my models when I'm doing, the big planning, what I do. So upper, lower, alternate, and start from there. Work your path through so that you are having predictable results, so that you have plane A, B, and C, and you know, okay, what is your aim and what is the path you have to take to reach that aim. Treatment modalities. Talk to the patient, because it's end of the day the patient who has to pay for it. So it should be a treatment plan which the patient at end of the day can afford and is happy to have this treatment. Regular checkups. So as I said, the more the merrier. If the patient is willing to come down and do a checkup the time you like, please do it, because extra checkup is better than too late. So, be very, very diligent with regular checkups. So I think with this, we have come to an end. And yes, I would really thank all the viewers and Global Summit for giving me this opportunity, and AAOS, American Academy of Oral Surgery, for allowing me to present my presentation. And it was a wonderful, wonderful session, and I'm very lucky to be here. Dankeschön. Thank you.
Hi.
Hi.
Hi, guys. I tell you, that was a fantastic presentation, madam.
Thank
And I
you.
tell you, I don't have a hat on right now, but if I did have a hat on, I'd take it off to you and bow
Thank
down
you.
to you. That was, I mean,
thank you, Pavel.
really beautiful.
Oh, thank you. Thank you so much.
This is like, summits, the world, Dr. Keanu Shar, Dr. Kayvon, Dr. Carlos, we're all a team here. We're a team of good people here, and this is what it's all about. It's about coming together. It's about sharing our passion together, and of course, in most situations, we're talking about why you're drinking water, young lady. I caught you. So the point is this: I love you all. Wonderful day, and we got another big one coming right after this one. My implant mic. All right, now implant mic. Look at my eyebrow. Oh, I showed you the wrong one. Look at the eyebrow here. You know what I'm saying? Implant mic. That's going to be a show in it of itself. So, Dr. Pai, first of all, you were fantastic. Right? Now, I got to ask you a couple of questions myself. I'm a general practitioner. I don't do this kind of huge, gigantic augmentations like you. And I read your resume before, but you and Dr. Vichy Brauman, you guys do this incredible cases with reconstructions, with cancer patients. I don't do that kind of stuff. For me, my everyday reality is I put 2 implants, 3 implants, 4 implants. I do a sinus lift here and there. You know what? But so let me ask you a question. When you do a lateral window sinus lift, do you open the window because the way I do it is usually I go with a burp until I start to see the membrane. All right. Then I switch to a piezo. So, but ultimately, how we get into the sinus is, it's a matter of opinion. But what I'd like to ask you, with your experience as a surgeon, is do you rotate the window itself into the sinus, or do you get rid of the window? Because I personally, and I can't, this is a matter of opinion. I like to use the window to form the new roof, but that's only when you have enough buccolingual space to rotate the window in. Because in some cases, if you have a narrow sinus, you cannot rotate that window in. So the question is, what is your preference? Do you like to rotate the window in, or do you like to get rid of the window and do your procedure? And my second question regarding that is, I usually like to use PRF, platelet-rich fibrin, and I make a membrane, and I usually put it in for insurance. Even when I'm almost positive there's no tear, I put the PRF membrane for insurance, and then I place my bone graft material. So give us some thoughts. And hold on, before I forget. So I'm so sorry, but you know me. With my age, I'm like the thing. I might start talking about Joe Biden, the thing. The guy forgets. I forget. I'm 52. He's 90, maybe 80. I don't even know. The point is this. Forget about it. I forget sometimes. Forgive me, people. But what you said earlier in the presentation regarding pain control, I think it's very important to manage the pain before the pain comes.
Absolutely.
And you mentioned that clearly. And I thank you for that. Now, in my practice, you guys can call me whatever you want. I can't remember last time I prescribed a narcotic. I give everybody Motrin. And then if the pain is too severe, I tell them take Motrin, ibuprofen, 600 with Tylenol, extra strength together as a combination. Now, where did I learn that? Back at NYU. Because at NYU, we had some big people that are experts on teaching at the implant program at NYU, New York University, when I was trained. And then I stayed to teach on there for about, 13, 14 years. But there we had some big people who knew what they're talking about, I think, at least from my experience. Ibuprofen plus Tylenol before the pain starts. So, all right, floor is all yours, and then we can take some questions, and then I'm going to give my big kiss to everybody and say goodbye.
Okay, Pavel, as you said, the way I prepare my window and whether I elevate it or either I elevate it, as you said, to use it as a roof of the augmentate, or when there are cases when I'm able to separate it from the Schneider-Scheier membrane, I tend to remove it and place it back after the external sinus lift is done. So it is basically on how you have the membrane. I think you would agree with me when you say every membrane is different. There are cases where it is very thin and it is difficult to just elevate the membrane, and there are cases where it just elevates. I also use piezo, due to the hydraulic dissection. You have wonderful, without the stress, you can elevate the membranes without tear. So I also, like you, use piezoelectric so that I can elevate the membrane properly. But the way I do it, it is the decision I take in the moment. I decide once I go in if I will be using it as a roof, or I will just tend to clean the area so that I can elevate, or if I'm very lucky, I separate it very slowly so that I can use it as a closure after I finish my sinus lifts. And in regard to the pain medications, as you said, I usually tend to tell my patients take ibuprofen, and if the pain is too severe, I mix it with novalgine sulfate. So the patients are happy with this kind, and with the PRF's procedures, as you mentioned, I have really few patients where you say, "Oh my God, he must be having a pain," and they come and say, "No, Dr. Pai, it was completely fine." I'm like, "Really? Don't kid." No, we have really wonderful results with this PRF. So ibuprofen with novalgine or ibuprofen with paracetamols. When I do larger cases in general anesthesia, the patients get cortisone IV so that there is less of swelling and pain. So that works fine.
So PRF is definitely the way to go in comparison to the older technology of PRP.
Yes.
PRF is the way to go.
PRP, yes.
Developing, and Dr. Carlos Morel Yeah, so that's the new stuff coming up. Great to know that. Listen, Dr. Pai, it's been a
Yes.
pleasure. Let's open the podium to a few questions. And thank you very much for
Thank you.
joining us
Thank you
and
so
for
much.
our invitation. And you know what, guys? I love you all, but let's get some
Thank
questions
you.
going if there is any. Pleasure. All right, guys.